Good morning, and thank you for joining us today for Kerwin Court's webinar. Sorry we're running a few minutes late. We were waiting for people to join. I think some people were having a few difficulties. So I'm really pleased you could join us today, and I'm hoping it's going to be the first of many Kerwin Court webinars. But today we're going to be talking about the neurobehavioural approach to rehabilitation. And this webinar really came out of a number of conversations I was having with clinicians working in other neuro rehab services, commissioners, referrers, just around kind of wanting to understand the neurobehavioural approach and what it offers and how it differs, but also understand who should they refer, who would be appropriate, but also some of the myths and misconceptions around the approach. So hopefully we won't have any technical difficulties, but hopefully you'll bear with us if we do. So today I'm really fortunate to have joining me Dr. Mike Oddy, who's a consultant neuropsychologist with over 40 years experience working in brain injury rehab, both in the NHS and the independent sector. And he was the clinical director of services for Disabilities Trust and the Brain Injury Rehab Trust from 2001 till your retirement in 2013, I believe, Mike.
Yes, that's correct. Yes, right at the end of 2013. It seems some time ago now.
Yes. And so Mike's going to be talking about a brief history of BIRT, of the Brain Injury Rehab Trust and the neurobehavioural model. I'll then come on to talk a little bit about the neurobehavioural model in practice and how we deliver it here at Kerwin Court. We're then going to have Sara Ramos de Silva talking about what we can achieve with the approach as well, our outcomes and our findings from that. So she'll be joining us shortly. We're also going to talk a little bit about the challenges that we face in the current climate and our opportunities and hopes for the future. And there's going to be the opportunity to ask questions at the end. So hopefully you'll notice on the right-hand side of your screen is a chat box. I don't know if you can all see each other's chats. I think on other webinars you haven't been able to see each other's chats. So if you can see each other's chats, you can let me know. But if you put questions there, some we'll address as we go along, but others will come to at the end in our, oh yeah, all chats visible, thank you. So some will come to at the end of the webinar. So feel free to ask whatever questions you want as we go along. But I'm now going to hand over to Mike, who's going to talk you through a brief history of the Brain Injury Rehab Trust.
Thank you, Jane. Thank you. On the slides here, they're not responding to me. Right, okay. So I'm going to talk about the origins of BIRT and how it developed. It takes its time to respond to me, but BIRT, as you may know, is a division of the Disabilities Trust, and the Disabilities Trust was originally the Disabled Housing Trust. It was founded in 1979 by Norman Oddy. Norman was a chap who'd had a successful career in the insurance industry, but found himself in the situation of having a son with cerebral palsy and a wife with muscular dystrophy. And this led him to realize how few and far between the services for such people were. So he decided to set up his own organization, a not-for-profit organization, initially with the aim of providing housing and care for those with physical disabilities. Now, in the 10 years that followed, Norman established Ernest Kleinwort Court in Burgess Hill, and then Shinewater in Eastbourne, and the Disabilities Trust grew from there. But in the 80s, particularly the late 80s, people were beginning to realize that there was a gap in services for people with acquired brain injury. And so once again, Norman thought he would address that gap. Now, this was at the time when Headway was starting up, and in consultation with Headway, Norman designed the BERT services. He recruited Dr. Roger Wood, now Professor Roger Wood, as the clinical neuropsychologist who worked at the Kemsley unit, helped set up the Kemsley unit with Dr. Peter Eames during the 80s. And he also recruited Colin Headley, who was a nurse and social worker by training, who had been working for Scope. And they looked at the situation and found that there were no, or very few, were no NHS services specifically for ABI in the UK. Services were usually much broader. They encompassed at least the whole of neurorehabilitation, stroke and so on. But sometimes they also embraced orthopedic rehab, even cardiac rehab. They were medically based and they were directed at those in the early stages of recovery, the more acute stages of recovery. So they identified a need for specialist brain injury services once the person was medically stable. Here we go. So what they designed was Thomas Edward Mitten House, the first BERT service in Milton Keynes. And a lot of the philosophy that they had is embodied in the name of the service. It wasn't called a centre, it wasn't called a unit, there was no brain injury in the title. It was simply called a house and it was named after a service user. Sorry about the lag between slides. So this is the interior of Thomas Edward Mitten House. As you can see, it looks more or less like an ordinary sitting room that anyone might have in their house. And this was the aim, to make it similar to carry out rehabilitation in a similar environment to that in which the person would normally live. And the rehabilitation was aimed at people with a range of cognitive, physical, and emotional symptoms or difficulties following a brain injury. And the rehabilitation was based on the neurobehavioural approach, which Roger had pioneered at the Kemsley unit. The rehabilitation focused on enabling the service user to function more independently. This was the aim, to participate in as many of their previous roles as they could, and to be able to carry out activities that they had previously done. Well, Bert developed rapidly and met his milestones early. Within a year of Thomas Edward Mitten House opening, Daniel Yorath House in Leeds opened. And that was followed, as you can see, by more services throughout the 1990s. The highlighted service, York House, was designated as a hospital. It was a joint endeavour with the Rowntree's, with the Quaker Trust in York. And it was on the site of the Retreat Hospital, which was a 200-year-old psychiatric hospital. But as you can see, the development continued from there. The highlighted ones here are slightly different from others. Goole was collaboration with the local NHS Trust, and Graham Anderson House in Glasgow was a neurobehavioural unit, again designated as a hospital, but developed in close liaison with the health board in Glasgow. So the team in these services were psychology led. They consisted of occupational therapists, physiotherapists, speech and language therapists. There was a head of care stroke assistant manager in each service, who was normally a general nurse, occasionally a psychiatric nurse, depending on the particular service provided. There were managers to the service, and there were the rehabilitation support workers, who in this model do the vast majority of work. They're the ones who spend the most time with the service users, and their supervision and training comes from the clinical team, but they become very expert in a very short time. Medical input is provided by a local GP and a visiting specialist. In some services, that's a neuropsychiatrist. In others, it's a consultant in rehabilitation medicine. What is neurobehavioural rehabilitation? Well, you'll hear a lot about it this morning, and Jane will tell you about it in more detail than I'm going to do. But briefly, I think it helps to divide the term up into its three main areas. The neuro bit refers to the fact that it's informed by our understanding of how the brain functions after a brain injury. What are the difficulties that arise? What are the changes in function? What are the losses of function that occur? Because we need to understand those in order to know how to address them and how to help people learn after a brain injury, because rehabilitation is very much a learning activity. The behavioural part refers to our reliance on theory and evidence from behavioural psychology. In particular, we stress the importance of being able to specify behaviours in ways which are observable and measurable. We've heard a lot about measuring behaviour in the recent months of coronavirus, but we got there first. We've been doing this for a long time. And then the rehabilitation refers to evidence-based practice, studies which have looked at rehabilitation and made various suggestions as to how it should be carried out, and generally accepted principles in the field of rehabilitation, such as the fact that rehabilitation should be functional, should be community-based, strategy-based, it should use SMART goals, it should be holistic in the sense of looking and addressing adjustment to disability. So neurobehavioural rehab is not just about challenging behaviour, a common misconception perhaps. It addresses all aspects of rehabilitation, whether it's physical and sensory rehabilitation, cognitive or challenging behaviour. It looks at rehabilitation in a functional way. It tries to replace and rejuvenate function, but function in terms of activities and performance of roles rather than individual pathology. And so what have we learned? Try and catch me out. I'll just, yes, let's go on to this one, that's fine. We've learned that good services thrive, but poor services can rapidly get worse. And one needs to monitor services. You need to know whether your service is thriving or not. If it isn't, clearly you need to act quickly to address that and to change that. But good services can become poorer and vice versa. So one needs to constantly be monitoring the service and intervening where necessary to change a particular direction. Also, funding is at the heart of all of this, and one has to be on one's toes about funding as well, because funding can disappear very quickly. and there's always a tendency towards funding becoming more and more difficult to obtain. Next slide, please. We've found that the nature of people referred to us or funded for our services has changed over time. It's changed in the direction of greater complexity of brain injury and complexity of disability. It's changed towards greater acuity, people coming earlier, sooner from general hospitals into our services. And we found that over time, fewer TBIs have been referred, more stroke patients have been referred, more females have been referred, and more older people have been referred. Next slide, please. There's also been a trend away from social service funding to national health service funding. And of course, this reflects a change in the nature of those referred. But it also means that we have to keep on our feet. Over the 30 years, there's been a gradual increase in awareness of brain injury. And commissioners in particular have become much more sophisticated in understanding brain injury and perhaps found more sophisticated arguments for not funding rehabilitation. So we have to be equally on our toes, and we have to be wise to this as well, and have more sophisticated answers and arguments as time goes by. Next slide, please. One of the greatest problems, if not the greatest problem, is the distinction between health needs and care needs. Next slide, please. Personal care is health. Behaviour that challenges is health. But physical support is social care. Cognitive support seems to be neither fish nor fowl. And the other difficulty with this distinction between social care and health care is the fact that they're in totally different sectors of governance. One is in central government, the NHS is in central government, and social care is in local government. And this adds another barrier, makes it even more difficult to secure funding and to design services. Next slide, please. Perhaps the holy grail of neurobehavioural funding is to find a measure that adequately reflects the benefits of community-based neurobehavioural brain injury post-acute rehabilitation. This has always been tricky because it's always seemed much harder to get something that reflected the outcomes and the process of neurobehavioural rehabilitation than in physical rehabilitation. And I'm hoping Sara later on will tell us that the Holy Grail has been found, but somehow that may not happen. So I don't want to raise your hopes too much. Last slide, please. So in conclusion, always pursue excellence in your service and monitor it and keep on your toes to ensure the continuance of excellence. And identify your source of funding, but don't relax. Don't assume that funding will simply continue because funding policies change, and there's a general tendency for funding to regress to the very mean. Thank you very much. Back to Jane, or on to Sara. Back to Jane, I think.
Yes, thank you, Mike. That was really interesting, and I'm really struck by how so many of the issues that were around in the 90s and early noughties are sort of continuing to this day, really, and we've still got the same.
Don't be discouraged.
So I'm going to talk a little bit about the neurobehavioural approach in practice, because I think that's often the question I get asked is, we talk about the neurobehavioural model, but it's that trying to understand, well, what does that actually look like in practice? Now, when I created this slide on PowerPoint, this was a lovely GIF of a dog. Obviously, it's not worked on Demio, but I thought it was a really good picture, and we thought this was a good quote to represent the neurobehavioural model, because it recognises that actually rehabilitation takes practice, it takes repetition, it takes time, and it takes re-evaluating. If an approach doesn't work, what can we do instead? How can we adapt? So I'm going to talk a little bit about what the model is, who can benefit from the model, what it looks like in practice, but also some of the myths that I come across very regularly about the neurobehavioural model. So the 90s didn't just bring us Britpop and the Spice Girls and New Labour, it also brought us developments in our understanding of brain injury rehab. There was a recognition that to work effectively, we needed to work across the disciplines, and the disciplines needed to work together. That it involved neuropsychology, OT, speech and language therapy, as well as physiotherapy, and thinking about how we support the learning process following a brain injury. But there was also the recognition that we needed to think about the psychological aspects of brain injury in terms of the psychotherapy required, behaviour analysis and cognitive retraining. So I want you to take you back to thinking yourself about learning a new skill and the things that you were required to learn those skills. So for me, the skill I've been trying to learn this year is sewing, so I can make these wonderful craft projects like all my friends seem to do on Facebook. Now, I've learned that buying a sewing machine, leaving it in the box for 5 years and then sporadically buying sewing patterns doesn't work. What I'm going to need is motivation, you need a positive outlook, I need the concentration and the attention to actually focus on the task. I need awareness of the difficulties, what I'm finding hard, what I need to practice. I need energy. I need to be able to remember previous learning so I can apply it the next time I go to the sewing machine, or don't, as is the case at the moment. And I need to repeat that task time and time again and reflect on what went well and what didn't. And then let's think about the impact of a brain injury. We all recognise fatigue's a huge factor. We all recognise the influence on cognition, so both memory, how we learn, how we acquire new skills and new learning, but also executive functioning. So our ability to plan, to problem solve, to use goal-directed behaviour, to inhibit behaviours, to initiate behaviours, to concentrate and attend to things. And then there's the mood factors, so the neurological impact on mood and fatigue and motivation, but also the psychosocial impact of having a brain injury and the adaptation to a very new life and the loss. And we can see how that knocks out straight away all those core skills that we rely on when we're learning any sort of new task. So when working with a brain injury, we can't ignore the full array of factors that influence someone's ability to engage and use rehab, to make the most of rehab. We can't just focus on the neurological and physical and cognitive factors. We also have to consider mood. We have to consider somebody's awareness and their own motivation and ability for kind of goal focus. We have to consider their personality. What does it mean to them in terms of the losses they've had? And we have to consider the society or the structure of society they're living in and their family. Otherwise, rehab's always going to be struggling against all those factors. So the neurobehavioural model, as Mike said, is not just about challenging behaviour. And I think people hear behavioural and assume it's just about challenging behaviour, and it's not. As Mike said, the neuro aspect really focuses on how the brain injury itself has impacted on a person's ability to learn new information and new skills. The executive functioning impact of the brain injury, so how it's affected initiation, motivation, sequencing, inhibiting responses, goal-directed behaviour, all those factors. And it also affects mood. So you have obviously the neurological impact on mood as well as the psychosocial impact on mood. The behavioural component, which I'm going to talk a little bit more about shortly, thinks about the processes of learning, and it focuses on implicit learning and operant conditioning, which I'm going to go into a bit more. But it recognises
the need for repetition and consistency. And that's really key to the approach, is that need to kind of have this experience 24/7. So it thinks about the biopsychosocial factors. And ultimately, it's rehabilitation. So it has to be evidence-based. We have to look at outcomes. We have to look at effectiveness. And it needs to be goal-focused. It needs to be focused on things that are meaningful to that individual. So they're person-centered. And it's thinking about supporting that person's re-engagement in their meaningful, valued roles. And I think the one thing that's really stood out for me in the neurobehavioural approach is that it's interdisciplinary, not multidisciplinary. So we're not just separate disciplines all happening to be working with the same person. We are very much working as a team on every single goal. So let me just move on to the next one. Okay, so I'm not going to assume you all know about operant conditioning. I know we have psychologists on the call, and it's, as Mike was saying, that kind of behavioural modelling and changing behaviour is a big thing on the news at the moment. And it's a big thing in government in terms of nudge psychology, and there are numerous self-help books now about how we change our behaviours, from the power of habit to nudge. But ultimately, operant conditioning recognises that whether a behaviour is likely to occur again is based on what happens immediately after the behaviour. So the premise is that the response experienced following an action will influence the future behaviour. And it recognises that the behaviour operates in an environment, so it's maintained by its consequences. And then the probability that it will occur again depends on whether it's reinforced or rewarded, and that can be both positive and negative reinforcement. Whether there's no reward, so there's no response to the behaviour, there's a loss of stimuli, whether the expected reward has been withheld, or if a behaviour has been punished. So these are sort of, processes that many people will be, who with young children will be kind of familiar with in terms of how you reward positive behaviour and how you extinguish not positive behaviour, but it's something we forget as adults influences us continually. So behaviours are maintained through constant delivery of reinforcement, including thinking about social attention. And they can also be maintained, and this is important to think about, by negative reinforcement. So avoiding a negative stimuli, so avoiding an activity that's concerning or challenging. So that kind of lays out that process, which I'm not going to go into here, as I think that there will be copies of the slide available. But the advantages of behavioural learning is that it allows for a clear set of procedures that can be followed. So for us, this is our guideline. So clear behavioural procedures to be following constantly. So it's a very objective and consistent approach. We're constantly assessing the environment and the behaviours to look at what's maintaining behaviours, what's strengthening them, what reduces behaviours. We use a range of monitoring techniques, which I'm going to talk about shortly. And then we also think about how to generalise those behaviours to a range of different environments. So it's not just within the unit that those behaviours are working. And it's a constant re-evaluation. So that's that kind of if at first you don't succeed. If it's not successful, then we have to, again, re-evaluate, reformulate, think what's the difficulty, what's causing the behaviour or causing the particular difficulties with engagement, and how we can adapt to that. So, who can benefit from a neurobehavioural approach? So there's a vast amount of literature on the neurobehavioural approach. So this is a bit of a brief overview, to say the least. But the evidence really suggests that the neurobehavioural approach can be beneficial when there are social, emotional, or executive functioning factors that might impact on whether someone can engage in neurorehab. And again, with some of the brain imaging studies, if brain imaging suggests that there might be social, emotional, or executive functioning networks involved, then these people might benefit from a neurobehavioural model. So, if brain imaging is picking up difficulties with frontal lobes, for example, or even a sort of subcortical areas knocking out those frontal networks. But one thing that really stands out is that characteristics vary from person to person. It's not just about the brain injury or the original pathology, it's also about the age of the person, premorbid personality factors, and family dynamics can influence how people can engage in neurorehab, but can also benefit from a neurobehavioural model. And another challenge is it's often difficult to pick out some of those challenges using standard neuropsychological assessments. So some of those executive functioning changes impacting on initiation, motivation, goal-directed behaviour can be very difficult to detect with standard neuropsychological assessments, but can cause huge disability for individuals and really inhibit their ability to get back to the activities that are meaningful for them. So I'm going to talk a little bit about what the model looks like in practice. Now, the challenge was actually how to condense this down into a very brief presentation, because we could have talked about lots of different examples. So I've picked, I'm going to kind of run you through our process of working with people, and then I've picked a couple of cases just to kind of give you an example of how that might look in practice. Okay. So the first stage with all neurorehab is that assessment and formulation stage. And at this point, it's when it starts first looking a bit different, I think, to some of the other neurorehab services I've worked in that it's interdisciplinary. So we're not separately coming up with our goals and coming up with our formulations about what needs to be worked on. This is very much together. It's neuropsychology led, so it's led by the models in neuropsychology around learning, around executive functioning, and around how to work with that. And it recognises the impact of neurological, physical, cognitive, psychological, behavioural, emotional, social and family factors, but most importantly, how they all may interact. And so, as you can see from my kind of diagram below, we're all involved in that formulation and assessment stage together. Okay. So this is a formulation tool. And again, you can see it's taking into account those sort of pre-injury factors in terms of family structure, personality type, coping styles, any other medical or psychosocial factors that might influence someone's approach to rehabilitation. And then it takes into account the brain injury itself and its impact on all factors from communication to cognition to mood and emotion and to the physical side as well. And also thinking about how that might look in a behavioural form and its impact on someone's functioning, where they can go. Okay. So the next stage is the goal setting. And again, this is interdisciplinary. So we don't have OT goals, physio goals, psychology goals. Within each goal, we think about the psychological, the communication, the occupational, the functional, the physical aspects that might impact on someone reaching that goal. And so the action plans are shared. The goals, very importantly, are person-centered. So they're goals that are meaningful to that person. I remember recently having someone who said, I've got no interest in making a hot drink or an easy meal, but I do want to work my lawnmower. So it varies massively from person to person what they want to spend the time on. And it's about social participation. It's about them re-engaging back into those valued activities. And the action plans are multidisciplinary or interdisciplinary. So the action plans wouldn't be an OT component, a physio component, a psychology component. They're all very much interacting. So this is an example, oh no, let me move it on. This is an example of a goal template, which I'm aware you probably can't read that well. But as you can see, we would have a kind of overall non-SMART goal, which would be the person's idealised goal. So in this case, they're wanting to go back to their own flat. And then we think about the specific SMART goals that they need to achieve that master goal, their overall aim. So one of this person's goals was being able to use their calendar so they could manage their routines through the day independently. So if we think about the skills required for using a calendar, sounds like such a simple goal, doesn't it? But they need episodic memory. So they need to learn what's being taught in any sessions that are focused on learning to use a calendar. They need to have attention. So they need to remember if they've kind of had a prompt to go and use their calendar and they get distracted on the way to the calendar, then it's not going to work. We need to think about communication. and visual processing skills. So how are we presenting the information in the calendar? How can they make sense of that information? Is it too complex? Is it too visually demanding? So as you can see, there's lots of different factors we need to think about in the rehab, in that multidisciplinary or interdisciplinary way. So we need to think about the implicit learning through that high repetition, errorless learning. We might think about the scaffolding provided. So that structure around the person with our rehab support workers who are verbally prompting and then moving on to thinking about what other environmental cues that person might have. So it might be assistive technology. We might want to think about the format of communication. So that might involve the psychologist and the speech language therapist thinking about how we make it visually simple and not so cognitively demanding to input that information. And it's ensuring that, as I said, that information is repetitive, thinking about using chaining and errorless learning and so forth. So, and I think this is where it starts to differ a little bit from some of the other units I've worked on over the years, but we deliver this rehab in 24 hours. So it's not, I'm often asked how many sessions of OT or sessions of physio or sessions of speech and language therapy someone's having in a week. But actually the aim is, alongside their therapy sessions with the clinicians themselves are also producing guidelines so that the approach is followed consistently 24 hours a day with the rehab support workers and all clinicians. So if, for example, someone had a specific communication technique that was beneficial, or we're wanting to support with attention or orientation, the rehab support workers have a very set way of interacting with that. So they're giving the same information repetitively. So the best way of thinking about it is as a prosthetic environment. So it's trying to make up for the loss of executive functioning skills, mood regulation skills, in providing that support around people to support that implicit learning of these skills. So it's constant reinforcement, and it's delivered in the form of a timetable. So if we're wanting to make sure people are able to utilise these skills regularly through the day, we would think about the activities where those skills can be used, and that would be timetabled in. So for example, if somebody's working on an upper limb movement goal, but also a communication goal, that might be worked into a cooking group, for example, following both of those guidelines. Okay. And it's constant process of re-evaluation. So as I talked about before, there's the assessment and formulation. We're then delivering the intervention. We then monitor that, and I'm going to come on to talk a little bit about that. And then we review whether it's been successful. Has the goal been achieved? And if not, then we have to go back to thinking about assessment and reformulation. Why hasn't it been achieved? How do we need to adapt the intervention? If it has been achieved, then we might think about how to support that and generalise it and maintain those skills. We use a range of different monitoring techniques. So ABCs that are reviewed on a daily basis to look at people's response to interventions and behaviours. We'll use observation. Each discipline might have its own specific measures to look for change. So Berg or the OSTOMs. And then we might have individual or guideline specific monitoring. So for example, if someone has an errorless learning strategy that they're following with their morning routine or whenever they're making a hot drink, we might use some monitoring specifically around the stages of that intervention. We also look at engagement and timetables. So if people aren't able to engage in their rehabilitation, that's a big part actually of the work, is thinking, how do we support engagement and what do we need to do differently? And obviously goal review. So reviewing, are we actually achieving the goals that we're setting out to do? And that's done very regularly, depending on how long people are here for and the type of intervention we're working with. So some types of goals or interventions will need longer to work. Others are kind of more short-term interventions. Okay, so I'm going to talk a little bit about case study. And this, I've got two case studies I'm going to talk about. So this was Mary, who presented with dysphagia, impacting both her receptive and expressive skills. She'd had a traumatic brain injury following being hit by a car, so following an RTA. Before her injury, she'd been working in an administrative role, and she was a mother of 2 primary age children and married. So the neurobehavioural model focused very much on supporting successful communication and reducing unsuccessful communication. So when she first came onto the unit, she was very she used a lot of jargonistic speech. She was often struggling to get her communication across and to explain what she was trying to say. She was often talking around the topic, what she was trying to say. So she was very tangential in her speech. And so she was often quite unsuccessful in being able to communicate with people. So within the speech and language therapy sessions, the strategies were developed around how to prompt her, and this was in collaboration with her, what prompts worked for her, how to prompt her when she was becoming tangential or going off topic, and how to target specific words and phrases to practice them through errorless learning, using both written and word stimuli. And then she moved on to semantic maps. But guidelines were produced for the rehab support workers so that they're reinforcing this approach in all of their communications with her. So they're using the prompting to stop techniques, the reminders of how to structure sentences or what point she needed to get into a sentence. And particularly that supported her being able to listen to instructions. If she was talking a lot, she often found it difficult to process the information she was being given. So she learned, for example, to make structure sentences kind of using 3 main points and so forth. Once she started successfully managing this on the unit, a range of different interactions, she would then move on to generalising that to more community settings with people that aren't familiar with her and she's not familiar with them. At the point of leaving the unit, she'd got to the point where she could communicate, she could get her message across, and mostly it was intelligible speech, but sometimes she would use other communication techniques, but she could always get her communication across. Okay. So this other case study, so a bit different this one. This is more looking at the kind of physio side, or kind of that interaction of psychology, physio, but also a bit around communication. So this was a 50-year-old woman with a left middle cerebral artery stroke. So she was having physio to support her in walking. This was one of her goals, was to be able to walk at home. So she wanted to return home, which meant she needed to be able to walk to the toilet and she needed to be able to walk to the kitchen. When she first came onto the unit, she was unable to sit unaided. So this was quite a big goal for her. And it became apparent during her physio sessions that they were being impacted by her attention. She was very distractible. And as soon as she became distracted, her balance just went and her focus on her body just went. It needed her full attention on her body to be able to perform the tasks. So that would just go. But also she'd become very anxious about the prospect of engaging in activities. And that was stopping her taking the next steps in rehab in terms of, say, moving into a flat or a bungalow. And it was apparent that if long sentences were used or a lot of verbal information, she just couldn't process all that information. So she was only getting kind of some of it, or it was taking up all her attention, so she couldn't focus on what was being said or her body. So the goal involved lots of disciplines in terms of, first, a bit of education around anxiety, what's happening to the body, what triggers it, understanding that, and learning techniques for managing that emotion regulation. So she was taught grounding techniques and mindfulness techniques in the psychology sessions, but then she would practice them every single day on the unit rather. And she was prompted to use grounding techniques when she became anxious in the moment. So it wasn't just a grounding session, it was actually constant prompting in the moment. We also thought about how we communicated with her to reduce that attentional load during the physiotherapy session. And we did some attentional work for her body. So this was learning to focus on the parts of her body that she needed to strengthen her attentional link to. So twice a day, she'd have training around focusing in on her foot position. So this is just part of the form that we used, but it gives you an idea of how we would be doing that. So we'd be monitoring her awareness of her foot position every single day, and this was happening twice a day. So we could see an improvement in her awareness of her foot positioning. Okay. So some of the myths about neurobehavioural rehabilitation, which I'm hoping I've addressed a little bit. So one of the most common ones I hear is it's for aggression and challenging behaviours. Actually, what it addresses is implicit learning. It addresses actually how we learn, but also particularly how we learn after brain injury. And it addresses the executive functioning, mood and emotional states that can impact on rehabilitation. And then does it mean it's only for people with this executive functioning? For most people following brain injury, there's some impact on, particularly in the early days, on attention, executive functioning and so forth, goal-directed behaviour, initiation. So it can often play a role with a lot of different people. Another common misconception I hear is it's only for the walking wounded. So I often get that in terms of Kerwin Court, is we just see the people with cognitive problems. We don't work with any physical problems. I'm going to talk a little bit about some of what we have available at Kerwin Court. So hopefully you'll recognise that's not the case, but actually difficulties with new learning and mood and executive functioning exist alongside all other disabilities. So it's important to think about those factors, otherwise people can't engage in the physiotherapy aspect of it. Another misconception is that rehab only really works in the first few months following a brain injury. There's some fantastic case studies in Barbara Wilson and Shay Bettridge's book on neuropsychological rehabilitation, looking at actually the level of progress that can be made, not over the months, but actually over the years, and even after a period when people might come back into rehabilitation. Because the neurobehavioural model works on behavioural learning processes, not just focusing on that neuroplasticity or reorganising of networks that is often the focus in the acute stage. Because it works on learning processes generally, it's actually applicable years after a brain injury. It works for everyone. So I wouldn't be doing justice to the unit without just talking a little bit about what we have here, because I think one of our advantages isn't just the neurobehavioural model, but the fantastic resources we've got. So within the main building, oh, I had to just, again, slide in the wrong order. So we're an interdisciplinary team. We've got neuro and clinical psychologists. We've got OTs, we've got physiotherapists, speech and language therapists, we've got a music therapist, and then assistant psychologists and therapy assistants. Not forgetting the recreational and vocational side of it, but we also have the rehab support workers, and that's what's really important, is they're not just providing the care, they're kind of delivering that rehab side 24/7. So they're a crucial part of that rehabilitation team. And we also have input from consultant in rehab medicine. We've got 16 ensuite bedrooms, but we've also got 2 self-contained flats. So that's a great opportunity to start progressing people towards independence. And we have 5 on-site bungalows, which again is a great opportunity for really testing out skills before people return home. So just showing you some of the resources we have. So this is the kind of main area. Where we've got therapy rooms, sort of shared dining and shared lounge area. We also have the physiotherapy gyms and a good deal of space outside. And we have the ADL skill training. So we have the ADL kitchens, the gardening areas, and the laundry rooms and so forth. And these aren't just used by OTs. This is where people will be practicing those skills every day, each day. So if, for example, someone's working on an errorless learning approach around making their lunch, they would be doing that every day with an RSW. And one thing that really is extremely useful is our bungalows. So lovely bungalows and a great opportunity for people to practice those independent skills. So I've talked to you a little bit about what we do, but I think Sara is now going to talk you through what that looks like in practice. So actually, what are our outcomes? What are we monitoring? Hello, Sara.
Hi, very interesting talk. Thank you. Yeah, so I will talk about outcomes. Jane already gave you some really rich descriptions of a couple of case studies. I'm going to look at a kind of more clinical group or population perspective. So it's kind of data, maybe more boring for some, but really important to show the impact at the group level, at the population level, not just at the level of individual people. So the difference we make overall. So before I go on and talk about it, I'll just give you an overview of what do we mean by this achievement and what measures we actually use. And Jane already talked about the individual measures that are used with each person, which may include behavior monitoring. We also use goal achievements. It's not listed there, but we also use specific therapy outcome measures. But BERT has, since its beginning, had a system of clinical outcome measures that is trying to look at the global change that occurs as a result of this interdisciplinary work. And the measures we currently use are the supervision rating scale, which is just assessing how much supervision a person needs from being independent all the way to being in a restricted, high secure hospital kind of setting. We also use the BERT independent living scales, which were adapted from the community disposition ratings that were developed by Wood and Eames. And these basically are a ranking and a kind of systematic way of evaluating people's discharge placement or placement on admission. So it's just a systematic way of ranking how independent is their living setting. And the last but not least of the measures we use is the Mayo Portland Adaptability Inventory, which is a scale developed in the United States by Malik and colleagues. And it's looking at a range of areas. I'll show you a slide in a moment, but it's looking at all of the areas that tend to be affected in the sort of post-acute stages of brain injury. Why do we use measures that are different, for example, from the United Kingdom Rehabilitation Outcomes Collaborative? Well, the main reason is that measures should reflect the goals of the rehabilitation program they are intended for. And you heard how Mike was explaining early on that the whole setting and the purpose of these units are to make the person ready to go into the community, so they have like a homely environment to them, so that the experience is much more like one of being at home and being in the community rather than being in hospital. And the outcome measures are also oriented to reflect that aspect of community integration, social participation. There's also some issues around the sensitivity of the measures in UK ROC in this population, because the nature of the difficulties is slightly different. So a study that we have taken part with the Independent Neurorehabilitation Providers Alliance in 2019, it has been published last year, was that we found that there were higher levels of sensitivity to change for the St Andrews and Swansea neurobehavioural outcome scale and the Mayo Portland Adaptability Inventory 4 than there were for the FIMFAM UK or the HONOS, which is the Health of the Nation scale for acquired brain injury. So those other measures, the UK ROC measures and the HONOS, tended to underestimate that they were less sensitive to change. And in terms of assessing complexity on admission, the rehabilitation complexity scale was not actually predicting who was changing over time. So it didn't really add very much in this patient group. I also want to just a very short word about to say that the outcomes I will be focusing on are those from our service users that have neurobehavioral difficulties. And you have a summary there around what this means. And obviously you've heard Jane talk about the details. One really important thing is that they do tend to have these difficulties in engaging with standard rehab, and typically they can be mobile and able to self-care, but in some cases they both have both difficulties with cognitive and emotional aspects, but also physical health needs and also mobility problems. So you can have both. It's not just the walking wounded, as Jane was saying. And where I can, I will compare these results with the more kind of restorative type of rehab profile, where these difficulties are not as primary. So this is just to give you an overview of the diagnosis. So as you can see, you can have any diagnosis in people with neurobehavioral symptoms. So it tends to be linked to traumatic brain injury, but it can occur in other types of injury, and particularly in stroke. You can see there about 32% of people actually had a stroke, but they did also have neurobehavioral difficulties. So the diagnosis is not always a good indicator, but it is true that quite a big proportion tend to have traumatic brain injury. In terms of how long since injury people are admitted, more and more people are being admitted soon since injury. This could be to do with the fact that there's increasing awareness that it's really important to offer rehabilitation in the early stages. But for all sorts of reasons, the people in the neurobehavioral group or with neurobehavioral symptoms tend to have a more widespread. So you can have some people being referred to a rehabilitation later since their injury, and even over 12 months. This is partly to do with the fact that sometimes these difficulties are not apparent while in hospital, or while people might move into their homes initially, and they might have some support. But then that support, for example, if a family member needs to go back to work. So sometimes the difficulties don't emerge immediately after discharge from hospital. They take longer. It's not until people start to try to resume their activities that they become apparent, and you can have people being referred later on, and this is more common for those with neurobehavioral difficulties. Also, in our hospitals, this pattern of how many comorbid problems is quite different. So in Kerwin Court, we see most people have 1 or 2 comorbid problems, and this includes things like mental health diagnoses like schizophrenia, substance misuse, and other medical conditions. And as you can see, there's a slight trend for people with neurobehavioral problems to have more comorbid problems, and in particular, what stood out was alcohol misuse. So it's quite, well, there's a considerable proportion who will present with some issues with alcohol use. But that doesn't mean they can't benefit from rehabilitation. In terms of placements before admission, more and more we are seeing people coming directly from hospital or from some form of residential setting like nursing home, for example. In some cases, it can happen that people are referred from the community, where they might be receiving support either from informal carers or from the family. But the vast majority comes from the acute setting and hospital. And the vast majority, again, needs full-time direct or indirect supervision on admission. And this is similar between the two groups. This is one illustration of the Mayo Portland Adaptability Inventory Scale. I can see actually not all the areas are covered in the slide. I think some of the items got squashed, but it measures mobility, use of hands, vision, audition, dizziness. And then you have the sort of more cognitive behavioral problems in the middle there. And the last items of the scale cover social participation, and this is to do with people's ability to engage in leisure, to live in an independent place or to have a job, for example. So it's a very broad, all-encompassing measure. And as you can see, there's some differences there. So as you might expect, people with neurobehavioral difficulties have poorer scores or are more likely to have severe difficulties with attention and memory. They're less likely to have physical problems like mobility and pain and fatigue. And also they have issues around self-awareness, more likely to have them at a severe level than the restorative group. In terms of therapeutic goal setting and achievement, we have started collecting these centrally so we can have like an overview of all our services and how we're doing. And in most cases, people can have SMART goals set within 4 weeks from admission. In some cases, this may take longer, especially in the neurobehavioral group or people with neurobehavioral features, because a lot of the symptoms might not become apparent until you start observing people in different situations after the admission from a hospital. So sometimes more time is required. On average, people have 6 total active goals per person. Obviously, this varies independently, but I think it just illustrates how hard work rehabilitation is and the range of things that people are working towards. We do not use currently goal attainment scaling for reasons that I could talk for a whole hour. We use a slightly simpler way of scoring goal achievement, which is whether people achieve the goal partially, which would be more or less the equivalent to less than expected in the goal attainment scaling format, and full achievement, which would be the same as expected or even better than expected. When I say we don't use, I mean when we gather the data centrally. Some units do score at the unit level, they do score with goal achievement, but centrally we look at partial and full achievement. And on average, we have about 70% of the goal achievement on discharge for the overall group, but obviously this varies slightly with individual people. Again, trends over time have meant that lengths of stay in service are shortening and shortening, in line with what Mike was saying earlier around the pressures in terms of funding. There's no huge difference between the two groups here. People tend to stay within 12 to 24 weeks on average, but in some cases they do need to stay a bit longer. Sometimes it's difficulties in terms of finding an appropriate discharge placement that will hopefully maximize the benefits that people achieved, and will kind of promote that continuation of those gains, and that may result in delays, which is part of the reason why sometimes people need to stay longer. Also, there's reductions in supervision. Here, this is just a snapshot showing that overall people tend to move towards more independent living settings, actually. So half returned home without support or with informal support. And then this is the reduction in supervision. And again, about half scoring independence on discharge. This is the change on the Mayo Portland Adaptability Inventory. You can compute overall global scores which cover impairment, or rather abilities, it's what it's called in the Mayo Portland adjustment, and social participation. I thought it would be interesting for you to see the actual individual changes across areas, and you can see there significant changes on non-verbal communication and attention, memory, and then also in the participation side of things, in terms of going to a more independent living setting and using transport, etc. Obviously, these are medians, so it kind of shows the overall profile for all the people we have seen with neurobehavioral, receiving neurobehavioral rehabilitation, but there are individual differences, of course. But by and large, you can see that there are changes for everyone. How do these results compare, and how do our outcomes compare with other kinds of reports? This is not always easy to answer because the data is not always available, and because the outcome measures need to be adapted to what you're actually delivering. Sometimes they're not actually comparable that easily, especially based on published data. But in a study, the IMPA study I mentioned earlier, that we did, we found that in neurobehavioral services, the sort of average rehab complexity score on admission was comparable to UK ROC services level B, and this is taken from the UK ROC triennial report. The full reference is provided at the end. We also, in terms of FIM-FAM on admission, the scores were closest to the scores seen in UK ROC level 1C services, which are supposed to be for more kind of neurobehavioral problems, and the same was seen for length of stay. In terms of reduction with supervision needs and changes on the Mayo Portland, our results are comparable with what has been reported by international neurobehavioral services. In the US, they have the traumatic brain injury model systems, where they have a system of global outcome measures that collects outcome measures from all the services across the country. And actually, the system we use in BERT was in the trust was inspired by that system, and our results are comparable. It's always very difficult, as I say, to compare because the populations where these measures are collected are not always the same, so the level of need on baseline are not always the same. But we certainly have comparable outcomes. Now, just a note about what this means in terms of lifetime savings and why we should invest in neurobehavioral rehabilitation. In a paper that Mike and I wrote back in 2013, where we tried to look at how much rehabilitation costs and how much the reductions in care achieved after rehabilitation will save over a period, a person's lifespan. And we found that savings could be as big as 1 million per person over a lifespan. The discount rates there are the sort of inflation rates, which at the moment is quite low. But it's just to show that even when these change, you can still obtain savings. But one of the things that we always felt is really important to emphasize is that, yes, it is true, people who are referred immediately or as soon as possible since injury benefit most, so they have more change. However, people who are admitted later on, more than 1 year post-injury, and this more than 1 year, it was a group that comprised people that were being admitted many years post-injury, you can still find benefits, and those also correspond to savings over time. And these savings took the cost of rehabilitation into account. So even not thinking about the wider benefits to the individual in terms of quality of life, being able to return to work potentially over the long term, and the benefits to the family as well. It just in terms of financial costs, it just makes sense. These are some of the references. I won't leave them on the screen for very long, but we will be able to send these to you. They will be included in the materials. And yeah, maybe I should invite Jane to join again so we can talk about challenges and threats.
Thank you.
for the future.
Okay. So thinking about some of the challenges that we're at a local level, and this has been touched on a little bit by both Mike and Sara, as funding sources have changed, or the focus of funding has changed more to health, the focus is often now on the kind of post-acute short-term interventions, and so that's being a sort of a big challenge for us is thinking how we adapt to that and how we adapt to what the need currently in the health economy is for brain injury rehab. But my concern is that that sort of model will only work for some people, and the risk is that some of the difficulties we've talked about with executive functioning, mood and engagement and so forth will simply be seen as challenging behaviours, or a sign that someone can't engage in rehabilitation. And we can see with people we're working with here at Cohen Court, often the indication is that they might struggle to engage in rehabilitation when they've tried to use more kind of therapy sessions-based intervention, but have actually done really well here under that neurobehavioural wraparound 24/7 type of rehab. So we're needing to adapt to that, and as Mike said, we need to keep thinking about the overall health economy and how the neurobehavioural model of rehab offered by BERT fits into that, where the need is. As Sara noted, the impact of neurobehavioural difficulties might not become apparent when people are in that acute stage of treatment. So it might become more apparent when people have been discharged home as families start to struggle to work. So again, it's that how we support people in accessing rehab at that point, so even once they've left that acute setting. And it's really recognising the support that can be provided for neurobehavioural disability and understanding the neurobehavioural model. One of the biggest challenges we're having at the moment is often we're asked a lot about how many hours of intervention someone's having, so how many sessions of OT or speech and language therapy. And because then they're having the therapy sessions plus the constant reinforcement through RSWs, we're trying to think how we can evidence that. So we can evidence actually how many hours of practice might have gone into an errorless learning task around cooking or making a hot drink or a morning routine, so that people funding placement can get that information. We feel that's quite important to provide. I think you were going to talk, Sara, weren't you, more about the kind of challenges in the area, really?
This is kind of trying to look at how the field needs to, the challenges to the field. One of the things is around recognizing hidden disability, and by recognizing here, I don't mean only, you know, realizing awareness that it is there and it exists. It's also around how can we best measure people's needs at different stages, and sort of channel people to the right pathways and make sure that we assess the outcomes in the best way. Mike was talking about the holy grail of outcome measures. Unfortunately, I don't think we are there yet. And it's a really big challenge because, again, you kind of need to match your measure to what you're trying to achieve. But yeah, so that's an ongoing challenge. How can we identify the best ways to measure these needs, especially around hidden disability, and then use those at a practical level. In terms of, there's also a challenge in terms of reflecting the full extent of rehabilitation benefits. So somebody was just asking around the cost savings that I just talked about and what they include. One of the major limitations of the paper was precisely that we only simply looked at costs with care. We did not look at whether healthcare changed over time and people, for example, reduced their need to go back to hospital, etc., as a result of understanding their condition better. There are some papers that did look at things like that, and family members being able to return to work because the person becomes more independent, etc. There's a wide range of indirect benefits or benefits sort of back into the health system that the paper we have written did not look at. So it's a good, it's an underestimation of the actual savings, but also in terms of benefits of the added value and of transdisciplinary working and the wider benefits. Lazak, a famous clinical neuropsychologist, used to say that brain injury is a family affair, and families are benefiting from rehabilitation at the individual level, but at the moment most of the focus is at the individual level for all sorts of reasons, including practical reasons. And one of the challenges is certainly really trying to understand the full extent of the benefits, and also the benefits over the longer term. What would happen if people had not received rehabilitation? We can see how people are before and after, and how they are in the longer term, and at least our follow-up data suggests that the benefits are maintained or even improved over the longer term. So there's something about having rehabilitation that maybe enables you to then achieve things when you are discharged that you would not otherwise be able to achieve, but that's very hard to demonstrate. Not that we're not trying ourselves and groups working in this area all across the world, but it's certainly a big challenge. And also, just in terms of rehabilitation in general, not just in terms of the neurobehavioural approach in particular, we still have quite poor understanding of what works for whom. We know that multidisciplinary and interdisciplinary rehabilitation is effective, but it's very difficult to determine because it's so bespoke and tailored to the individual needs, as it should be. It's then very hard to look at the population or clinical group level and understand what's working for whom. Exactly. So what intervention should be given? You know, if you think about that medication, you can usually read the indications. This medication is indicated for people with these problems and they should take this dose for X amount of time. We're not there yet in the science of rehabilitation. We don't have that understanding, and even more challenging to gain that understanding around this transdisciplinary working and what Jane was saying around the local level. How can we show the inputs, but also the outcomes that are achieved around that errorless learning and so on. So really big challenges to overcome, but these are sort of the main ones to the area that we want to highlight.
Okay, so thinking about our hopes for the future. You know, obviously we've got kind of bigger hopes and then hopes at a local level. We've got the resources here of having the bungalows and flats, and we're looking at how we can use assistive technology within those settings, both on the unit but particularly within the bungalows, to support people moving towards independence. In fact, that was one of the questions, is whether we use assistive technology. So yes, that's something we're really keen on, and Dr. Brian O'Neill, who's the consultant psychologist at the Graham Anderson House in Glasgow, is kind of really leading on that, and has conducted some research in that area. And assistive technology has become so much simpler and accessible now on everyone's phones. So even in the past 5 to 10 years, it's become much more practical to offer that. We're also really hoping to look at virtual and augmented reality to support the rehab process. So that's, you know, kind of COVID obviously gets in the way of lots of ideas and projects, but that's something we'd like to really integrate into our work. One aspect is also thinking about community support. So one of the questions I had noticed was whether we refer on to community teams. We do. They often have long waiting lists, and it's often a challenge to keep the progress going when people are discharged. Also, there's the specific support around the neurobehavioural model that we're wanting to hand over to families. So we do have community houses at the moment where we can provide neuropsychology input to support that model. But one of the things we'd love to look at in the future is that opportunity to be supporting families when people are discharged in continuing to apply that model and that support at home. And one of the things Sara was talking about is the different pathways and really kind of recognising that demand for the short-term post-acute rehab as well as the longer-term slow stream rehabilitation. The little bit that we've touched on is how we capture that information about the 24-hour nature of neurobehavioural rehab and the cost effectiveness of intradisciplinary working. So it's recognising, the whole is greater than the sum of the parts, that the benefit we get from working together is greater than just simply having those disciplines involved. I don't know if you want to come on to the next part, Sara. These are kind of very much your
Yeah, I think
you touched a little bit on them already.
Do hope to get better at demonstrating the complexity of change. So as I was saying, for example, on paper that Mike and I wrote about cost effectiveness, we just looked at the care aspect. We didn't look at health and societal benefits. But these are things that we can look at. I think that there may need to be some developments in terms of better data integration as well across the pathway for people, because we collect our outcomes and we know what happens before and after our unit, but there's limited linkage between the different stages from all the way from hospital into community settings and going on. So that's one of the things that maybe won't be achieved quickly, but certainly that needs to be developed in tandem with government initiatives and changes as well. So there's a lot of this idea of integrating health and social care, and certainly the department is now health and social care, but how can we reflect that? And also, how can we use new technologies as measures of outcome in themselves? So, for example, smart home technology can allow you to see how a person is doing while they're at home independently, and whether or not they're doing their sort of regular activities. Virtual reality, we have had some projects with the University of Bath around this. And one of the things we were trying to explore is how we can use the sort of more objective indicators of how a person explores the virtual environment and how long they take to do tasks, and use that as a measure of outcome. So there are possibilities that technology might enable obtaining some more objective measures. And yeah, then combining all of that, but by having the more kind of information you have and in different settings. So for example, the smart home technology would enable you to have, assess people while they go home and so on. So that may enable us in future to look at these kind of longer term outcomes. But there's also a big aspect in terms of impacting on society and wider impact as well that we're still to crack, but we hope to. And we're certainly working with different groups to try and start to address those. Jane, I'm not sure, maybe this is one for both of us, really. It's this sort of balance, isn't it, around, rehabilitation is a very profoundly bespoke intervention. It really needs to be tailored to the individual needs and to the person's goals. But then how then you translate those gains in a way that can show evidence of clinical effectiveness for the wider group. So it's not just for Mr. Smith, which is extremely important, but from a sort of service level and the healthcare system development and social care and society, really, we need to kind of be able to demonstrate those changes at the wider clinical group level in terms of developing the science. So I think there's a big challenge there. And we hope to be able to, you know, start finding that balance. We certainly, one of the things we've been working on, we tried to do that in this talk, so you could see Jane's sort of more qualitative and individual aspects of outcomes. And then you saw my talk, which is looking more at the population level. We are continuing to publish our annual outcome reports. It's been a little bit delayed with all this crazy 2020 year, but we are hoping to publish the outcome reports for birds later this year, and that will also provide an illustration of individual cases to give you a flavor of what happens and what the individual achievements are. What does it mean, all those numbers, but it also kind of gives some sort of quantitative data to provide that benchmark and comparison and understanding of what the benefits are for the group. So we do try to make a small dent in this, but it's probably a long-term effort.
And it's interesting, some of the questions are related to things like why we don't use gas and so forth. I wonder if it'd be good now to maybe move on to the questions and answers section, so we give time to address some of those. And I think Mike's going to be joining us as well for this section.
Yeah, I think maybe we can talk a little bit about that gas. I can talk about maybe at the sort of metric level and the challenges. So in terms of neurobehavioral rehabilitation, because we sometimes look at things like you know, depression, adjustment, sort of things that by their nature are hard to objectively measure with measures like, for example, if you think about physio, you can say that somebody has become quicker to walk, or they've improved strength and so on. For some of our goals and our measures, it's harder to identify measures, and for gas to be used properly, you need to identify not only a very specific measure, but then you need to determine in advance for each level, and gas has 6 levels. So you need to operationally define each of those levels, which practically can become quite time-consuming and difficult to do, especially if people have multiple goals. And then there's issues around showing the outcomes to people. Gas is from -2 to +2. Obviously, you can adapt and translate that in a different format to the individual. But I suppose at the metric level, the biggest challenge is around having that time and ability to establish in advance operationally what does it mean for each individual goal, what it is to have much better than expected, what it is to have a little better than expected. So that can take a long time, and it's not always easy to do. And that's why we use a slightly simpler system, which is still looking at goals and rating goals. Jane, I don't know if you want to comment from a sort of more practical perspective around that.
I mean, I think you've kind of addressed the question really well there, Sara, and I'm aware we've got quite a few questions to answer, and I'm not wanting to go over too much for time, as I'm sure people have got things to move on to. But we did have a question about, we talked about the kind of change in complexity and change in profile of referrals, and there was a question about where are people with traumatic brain injuries going? Are they still receiving rehab if we're experiencing more kind of referrals for stroke? I'd say the referrals are changing, but there's still the need for people with traumatic brain injuries to have rehab. So it's not that we're getting less of those, it's just we're getting more stroke, I would say.
Yes, I think I agree with that, although of course I'm out of date. But I mean, there has been a trend towards greater numbers of beds being available. So it's not necessarily that that those people are not getting the service, but that other people are getting it as well.
Yeah, absolutely.
I think also I've always thought there's an important distinction between hemorrhagic stroke and thrombotic stroke, in the sense that hemorrhagic strokes are very similar to people with acquired brain injury or to people with traumatic brain injury, whereas thrombotic strokes are a bit different and perhaps do need a separate and different service.
Yeah, I also wonder whether there may be a reduction in people being admitted longer since injury. So because we're getting more admissions of acute, I think with traumatic brain injury, there may be a risk of people who used to be referred more than 1 year post-injury that may actually say they refuse rehabilitation or not being sort of more moderate injuries might actually be missed, but it's an empirical question, and we would have to look at it. But certainly, it is true that in terms of the referrals to our services, we have more strokes, but we still have the actual pattern of traumatic brain injuries that has plateaued. So it was the stroke that increased, and that goes in line, as Mike was saying, with the more number of beds becoming available as well.
Yeah, absolutely. So I'm aware we've sort of come to the end of our session, and there's lots of questions now coming in. But what I would say is that we'll answer all your questions separately after this session. We can continue to answer some of them now, but obviously I don't want people kind of missing out on what those answers are for the people that do need to leave. So all the questions that are popping up into the Q&A box at the moment, into the chat box, we will address them, and so we can come back to you afterwards. But thank you for joining us today, and I hope it's been informative. Oh, apparently the sound has stopped working, somebody has said. Hopefully that's not for everyone. But yes, thank you for joining us today, and I hope it's been informative. And one of the questions is whether you can have reference lists. Absolutely, we can send out some references. And if there's any other information or kind of things you're interested in or you'd like to talk about further, please do get in touch. You've kind of got our details, so I hope it was helpful. Thank you.
Thank you.